Hello guys, this is Jonathan Munoz, and today we're gonna do another talk on one of these topics. I would like you to focus your observerships, your internship, the way that you conduct yourself during the interview process. And this is today about clinical documentation improvement or clinical documentation. Let's call it clinical documentation. Let's call it clinical documentation, okay? In United States, this is called CDI, clinical documentation improvement. Over the last years, they modify it to say, instead of improvement, they modify it to say clinical documentation integrity. So instead of trying to modify diagnosis to increase severity or to increase complexity, with changing it to integrity, it's supposed to be more accurate to what the patient is going through. But for practical purposes, when you start interacting with residents, start interacting with program directors, the word is the same: clinical documentation improvement or clinical documentation integrity. That's the difference. Improvement meant that we were trying to improve our documentation. Integrity means that we're trying to find accurate diagnosis based on what the patient is going through. It's about the same, but integrity sounds a little nicer, and it was recently adopted. So why is this important? So clinical documentation improvement or integrity in hospitals are their own department. They have a specific department that oversees every single note that it's written or typed, to make sure that the diagnosis that is written there, it's a medical diagnosis. Why? Because the most accurate the diagnosis is, a different score it's assigned for severity, for mortality, and of course the payments for that patient are different than a patient that has lower scores diagnosis. So let's put it in perspective. Let's say a patient comes to the ER and you say, problem number 1, shortness of breath. That patient, that accuracy, that severity is very low, very low. But then another resident comes and says, shortness of breath due to pneumonia. That has a little more, so it is more accurate. Now the complexity of this patient is higher. The mortality risk is higher. The resources that will patient utilize in theory are more and becomes more expensive to the system than the other one who only has shortness of breath or of non-specific reasons. And then a more seasoned resident comes and says, acute hypoxic respiratory failure due to pneumonia from Pseudomonas aeruginosa. That severity is the highest severity. That diagnosis has the highest complexity, mortality risk. That diagnosis pays way more than the others. Now, what is important is not that this diagnosis pays more than the others. What is important is that this diagnosis portrays severity, mortality risk, and the patient's condition at the most accurate state. So that is clinical documentation improvement or integrity, trying to portray exactly what the patient is going through, so we can determine scores, we can determine rates, or we can determine the severity of this patient. And it applies for every single patient. So, and why is it important for you as a resident, as an intern? Because people that are just starting to work in residency, or students, they don't know about this. They think it's okay to say shortness of breath, it's okay to say rectal bleeding, as opposed to acute blood loss anemia due to GI bleeding. Or it's okay to say hypotension instead of saying hemorrhagic shock from GI bleeding. So different conditions have a very specific way to diagnose this. And where does this come from? It's not set in stone. It comes from your knowledge, from your experience, from you reading books, to trying to really bring a problem to a medical term. For example, a patient that has pancreatitis. Most residents will say acute pancreatitis. A resident that knows more about the importance of documentation will try to catch every single problem in that patient's chart and will say acute pancreatitis is problem number 1. Problem number 2 is that this patient is going through SIRS. He has tachypnea, tachycardia. And the reason is non-infectious, is acute pancreatitis. So that patient's severity is way higher. So why is this important for students, for residents? Because as a resident, you are doing the work that an attending should be doing. So you're doing is the attending's responsibility. And when a note is presented to the hospital people that does this part of revising the charts, they will send this note that you are writing or typing. They will send this note to the attending to say, hey, did you mean acute pancreatitis, chronic pancreatitis, SIRS, sepsis, what? And the less notes that this attending has to revise, the less notes that this attending has to go through, because there are need for clarification, the more recognition this resident will get. And they want that. Me as an attending, I would like to get less interruptions in my day for clarification of notes if I have a good resident. So now that you understand what's the importance of clinical documentation improvement or integrity, put it on perspective. When you are doing an observership, let's say you're doing an observership, outpatient or inpatient medicine, any specialty, because all specialties are subject to this, try always to go to the most specific way to list a diagnosis. If you think that this patient has sepsis, these are the biggest one. If you think that this patient has sepsis, try to make the differentiation between sepsis, severe sepsis, or septic shock. And an explanation should be part of that description. If the patient has hypotension, try to find if this is hemorrhagic shock, cardiogenic shock, neurogenic shock, hypovolemic shock, and why. And if this patient is altered, don't write altered mental status. Write acute encephalopathy due to hyponatremia, hypoglycemia. And if this patient has liver cirrhosis, try to make the differentiation between alcoholic liver cirrhosis, viral liver cirrhosis from hepatitis, or from NASH. So when you do these rotations and your attendings or your supervising residents see you doing this, they will know that you know a little more, that your knowledge is real, it's measurable, that they can see how your presentations are of higher quality than other students. So you will be on their eyes. And when you go to your interviews, maybe you get into a courtesy interview where you are doing your observership, or maybe you get an interview during interview season. Try to incorporate this clinical documentation improvement to your answers. For example, to tell me about yourself. Instead of going through a whole speech about how your life was very sad and you went through so many problems and many issues, try to say straight to the point. I have a big interest on antibiotic stewardship, end of life care, and clinical documentation improvement, with goals to always try to portray accurate severity, the accurate complexity of each patient that I'm involved with. And I strive to make sure that my colleagues understand the importance of this. Or when they ask you, what are your strengths? One of my strengths is that I try to describe medical conditions to the most accurate that I can. I try to be very specific when I describe conditions. I try to dig deep onto why a patient has a problem like sepsis and explains, substantiate the reason why I think this patient has sepsis or has GI bleeding. Because I think that the more information that a patient's chart has, it helps to the continuity of care. If a primary care doctor receives my notes and he has a good explanation of what happened to this patient while he was hospitalized, he will understand what is his role at discharge. He will understand what he needs to do to continue the treatment that was started in the hospital, and things won't get lost in the middle. And this patient is less likely to be readmitted to the hospital. Now, I mentioned a couple of things. I mentioned continuity of care, endorsing care to the primary care doctor who is the patient's doctor outside the hospital, and discharge process. Why? Because that is part of clinical documentation improvement. Because your notes, when you write a discharge note, you have to be very accurate, saying the plan for this patient at discharge is to continue antibiotic for 14 days and to repeat a CBC in 2 weeks at the end of the treatment, because we need to ensure that his creatinine levels are stable and his liver hasn't been damaged. So that part ensuring that this connection happens has been proven in studies that decreases readmission rates to the hospital, which is a big thing for any program director, because a patient that returns to the hospital who was under your care returns. Why? Because your plan failed. Either your plan failed or they failed to take the medications. But if they were taking the medications, then your plan failed. So the less readmissions that you have, the better work you're doing. Of course, in some situations you cannot avoid readmissions, but it's kind of the idea. So don't try to look at the details of this. Read into this on your own. Read about what is clinical documentation improvement. Incorporate this to your thoughts when you do observerships, or when you go to interviews, or when you talk to someone that you want to impress about your knowledge of the healthcare system in the United States, and it will likely help. Believe me, I am here to help you, and all these videos, think about this, all these videos is because I want the international medical graduate community to reach their goals. So I'm giving you pieces of information that will help your application. But you have to believe me, you have to do your own research, and you have to practice to be able to apply this to these conversations during these observerships, interviews. So that's it for today, and good luck, guys.